Welcome all. Thank you for joining us for the session on Medicaid 101. We're really excited to be here with you all today, and hopefully this will be a fun, informative session for you. Throughout the session, if you have questions, pop them into the chat. We'll be monitoring the chat. And please feel free to introduce yourselves, your name, your org, your position, your pronouns. And yeah, so we're gonna get started. Next slide, please. So this is just a very quick disclaimer. This Medicaid Academy is being put on by the Healthcare Authority, and CSH is the content expert for this, but doesn't necessarily reflect C's views. But next slide, please. Very quickly about CSH, we're a national nonprofit with regional offices throughout the country. And we focus on all things supportive housing in the intersection of housing with other systems, right? Justice, health, child welfare. So we really work at the intersections of all of those to kind of build gaps and tear down walls and build partnerships with different systems to support folks who are touching all of those systems. Next slide, please. Very quickly about us, my name is Stephanie Cabrera. I use she, her pronouns. I am with CSH, the Corporation for Supportive Housing. I'm a senior program manager, and I'm in Vancouver, Washington. So I'm here with all of you. Eva.
Hi, everyone. My name is Eva Lerner. I am a senior program manager on our national consulting team. So I'm actually based out of New York City, but my primary role at CSH is to engage in all of our work that operates at the intersection of healthcare, housing, and homelessness. So looking at ways that we can leverage healthcare dollars to invest in housing and homelessness solutions, building cross-sector partnerships between these historically very siloed sectors that tend to work with the same individuals. So that's my role here. I'm really excited to work with all of you on this Medicaid work, which may seem a bit dry, but I think we've got a good training in store for you today.
And I wanted to give Rayanne from the Healthcare Authority a chance to jump on and introduce herself.
Thank you. Good morning, everybody. Super excited that so many folks signed up. And just again, thank you, Stephanie and Eva, for being able to kind of facilitate and lead us through all of this learning. My name is Rayanne. I'm with the Healthcare Authority. I'm the Foundational Community Support Program Manager, and I'm the one that kind of coordinated with CSH due to what we heard from all of you saying Medicaid is really complicated, and we would like it to be broken down a little bit differently so that we can understand it in a different way, and how it plays all together. So thank you for telling us what you need, and we hope that this is helpful today and that you give us some feedback on what else you'd like to see in the future. Thanks, guys.
Thank you, Rayanne. Next slide, please, Eva. So we want to hear first where you're all from. If you look at the view options tab, when I'm looking at Eva's sharing her screen, there's a view options option at the top, and there's an annotate button. You can select and kind of mark where you are on this map so that we get an idea of where folks are joining us from. I'm going to put myself there. Cool. Looks like we have a lot of folks in Western Washington joining us.
You saw that I put my star off the map because I'm in New York City.
That's pretty cool. Some folks in Clark County. So we're neighbors, y'all. Thurston County. I'm actually in Thurston County right now, so I guess I'm more neighbors with you all than I am with the Clark County folks. And look, we do have some folks from Eastern Washington. That's exciting. Thank you all for joining. So folks from kind of all around the state. Very different experiences, I'm sure, in the services that you're providing. Very different experience, I'm sure, in your experience with Medicaid, if you have it. Thank you all for sharing that with us. We have some folks who are not able to annotate, so they're sharing with us in the chat. Snohomish County, Lopez Island. I have no idea where Lopez Island is. Sounds like a fun place to be, I think. Is it? Stephanie, is it a fun place to be? King County, Cat County. Cool. Yeah. So kind of all over. Yeah, thank you all for sharing. I think that just kind of seeing we have 30 people in a room huddled around the screen in Aberdeen. Well, welcome 30 people from Aberdeen. Thank you for being here. I wonder, are there a lot of teams joining like that, or do we have more than the 670 people attending the session than it says? That's really cool that you're doing this as a team also. I think it's a great learning experience to do like as a cohort.
Absolutely. So we're gonna close out the map. If you are new and did not have a chance to annotate, please feel free to introduce yourself in the chat. And let's clear the viewers' drawings. Let's clear all drawings. And we'll go to the next slide.
All right, I'm gonna launch a poll. Let me know if y'all see it. Did it pop up?
Yes.
Yes, perfect. Thank you. It's my first time launching a Zoom poll. So the question is, what is your organization's current status with billing for Medicaid or billing Medicaid for FCS services? You're doing it, are you working with somebody with another organization who does it, never done it, but you have staff? You've never done it and you have no staff that have ever done it before. It looks like a pretty good mix. About half of you are currently billing for supportive housing or supported employment. Give folks just a couple more, 15 more seconds-ish to kind of serve. Yeah, so we're looking at around half of you, 44% of you are currently billing, 25% of you, so a quarter of you have not billed and don't have staff that know or that have billed before, and a good break or about even between folks that are partnering with other agencies or folks that have never billed but do have some staff with some experience. So thank you all for sharing that. That's, like I said, a wide range of experience in this group. So hopefully a lot of learning that you can do from each other in the chat as you're dropping in questions, as you're asking questions. Cool. Thank you all. Oh. All right. So today's agenda, very briefly, will be what is Medicaid? Why are we talking about it? And how can we leverage it? And so Eva's really going to do a deep dive into most of these topics. And we're going to just jump right in. So Eva, I'm going to hand it over to you.
All right. Thanks, Stephanie. Hi, everyone. So the big question, why are we all here? What is Medicaid? All right. So Medicaid is the country's free health insurance coverage. It provides free or low cost health coverage to millions of Americans, including eligible low-income adults, children, pregnant women, elderly adults, people with disabilities, and in the case of foundational community supports, folks experiencing homelessness. So today we're going to cover what the history of a brief history of Medicaid, its structure, its funding sources, the various players and stakeholders, and the landscape both nationally and here in Washington. So a brief history of Medicaid. Medicaid was authorized in 1965 under Section 19 of the Social Security Act. In 1972, it became the counterpart for Medicare, which meant that now folks eligible for Social Security income benefits, so low-income SSI benefits, can be covered. And in the early 90s, Medicaid was expanded to cover low-income pregnant women and children. So as you can see, over time, it's starting to grow, it's starting to expand to incorporate a number of additional populations, recognizing how important health insurance coverage is to overall health and health access. In 1997, the Balanced Budget Act created Medicaid managed care options and requirements for states. So that meant that we were moving from a fee-for-service model in which Medicaid was paid directly by the state's Medicaid agency, and instead states could opt into managed care, in which MCOs, managed care organizations, are what we think of as like your insurance provider. They're the ones who are responsible for paying out benefits. And in 2010, Obamacare, the Affordable Care Act, was signed into law, and that was a huge coup for so many people because it expanded eligible populations to include all low-income individuals and required additional basic health services and preventative care. So this was a huge opportunity to bring a number of previously unserved individuals into Medicaid. And in 2014, Washington officially concluded its expansion. Medicaid expansion means we expanded the eligible population to these additional folks who were now included. As you may remember, states had the opportunity to opt in to Medicaid expansion, and I think there's about maybe 13 or 14 states in the union who still have not opted into Medicaid expansion, so the vast majority have. And Washington was one of the first states to really kick that off back in 2022, and this granted coverage to more than 750,000 new beneficiaries by 2022. So a huge number of the folks that we serve were now able to receive Medicaid benefits. In 2015, CMS, which is the Center for Medicaid Services, or the federal government's overarching Medicaid administrator, Medicaid agency, they put out a letter, and we're going to go into this in more detail, basically recognizing that Medicaid can pay for housing-related services. So the folks in the Zoom room who are supportive housing providers, who maybe provide those housing case management, tenancy supporting, tenancy sustaining services that were not previously eligible to be paid for by Medicaid, as of 2015, CMS said, this is important, we're going to pay for it. And in 2018, Washington's 1115 waiver, and we're going to discuss these waivers in a bit in more detail. The 1115 waiver was approved, and this created the Foundational Community Supports Program. This is why we're all in the room. We all want to take advantage of the benefits in the 1115 waiver, the Foundational Community Supports, supportive housing, and supported employment benefits to help cover the services we're providing. And very recently, in 2023, this 1115 waiver amendment was approved. So the extension was granted, and an amendment was added on to include additional coverage for both rental assistance in certain instances. So actually paying for rent for folks who are experiencing or coming out of homelessness or institutionalization, as well as what we would call other health-related social needs, or these sort of upstream social determinants of health. And we're going to discuss that in more detail in future slides as well. So what is Medicaid from a financial standpoint? Well, it's a federal financial partnership. So this means that the federal government is going to invest as well as the state. So for every dollar that the state invests, the federal government's going to invest $1 as well. So that means that there's federal oversight and structure. I referenced the CMS, or the Center for Medicaid Services. They provide federal oversight and structure, but there is significant state flexibility. State legislatures at the budget, they can determine A, whether or not they want to opt into expansion, and B, whether or not they want, what services they want to include in their state Medicaid plan. And these state Medicaid plans outline how Medicaid works in the state. So CMS is going to provide overall guidance on specific services or healthcare benefits that Medicaid has to include. And then states have some flexibility about additional services they want to cover. And that tends to be incorporated in these 1115 waivers that we referenced. That's what Foundational Community Supports is. So Medicaid in Washington is called Apple Health. You may have heard of Apple Health. You probably have participants who are on Apple Health. You may be on Apple Health yourself. And as I mentioned, the federal government funds 50% or more, and the state government funds 50% or less. Those two funds come together to provide and cover and pay for Apple Health. So there are three sort of overarching administrators, governance structures when it comes to Medicaid. You've got the federal government, which is the Center for Medicaid Services, and they provide all of the federal regulations. They're the centralized payer. Then there's the Department of Health and Human Services, under which CMS lives, and that is overseen by Javier Becerra, the Secretary for Health and Human Services. And then CMS itself has a Medicaid director. Then there's the state Medicaid agency in Washington. That's the Washington Healthcare Authority. And they are the ones who oversee and pay for Apple Health. Within Apple Health is the Housing and Employment Related Services Program, and that's Foundational Community Supports. And the authority that pays for that grants the state the ability to actually implement and pay for this work is called an 1115 demonstration waiver. And what an 1115 demonstration waiver says is that it gives the state the right to waive certain requirements in order to provide additional services not traditionally covered by Medicaid. And we call it a demonstration waiver because they tend to be implemented in 5-year increments. And the idea is to test or demonstrate new models for Medicaid, new payment models that we hope will achieve the triple aim of improving healthcare coverage and access, improving overall health and population health goals, and improving the patient experience in the state and with their healthcare. And so it's this idea of demonstrating or testing new models. And when I see that they're waiving certain requirements, what it basically says is Medicaid, generally speaking, all individuals who receive Medicaid have to receive the same coverage. Everyone is entitled to the same healthcare benefits if they're on Medicaid. However, with a waiver, they're waiving certain requirements like entitlement for everybody or eligibility for everyone in favor of saying, okay, well, we recognize that certain individuals may need extra support. So we're going to target those individuals with this coverage. And within foundational community supports, we recognize that it's folks with chronic health conditions, folks with chronic behavioral health, folks experiencing homelessness. So the program is limited to benefit those individuals. And then finally, we reference managed care organizations. They're the ones who actually do the paying. They're the ones who contract with providers. So we have managed care organizations, which generally are the ones that are responsible for building a network of providers and who will pay out claims and who your clients, patients, members, participants are going to be a member of. But then the foundational community supports program is a little different. They have a third-party administrator. And this third-party administrator is a managed care organization as well, WellPoint. But instead of having FCS providers contract with any number of managed care organizations, they only have to work with WellPoint specifically for foundational community support services. For all other care that's overseen by Medicaid, managed care organizations are responsible for that, and that's outlined by county. But for the purposes of FCS, you only have to think about WellPoint as being the managed care provider that you're working with. And if you want further information about any of these entities, when we share the links out or share the slides out, you can click on these links. So when we talk about Medicaid, there's Medicaid eligibility and then there's Medicaid enrollment, and it's really important that you not mistake the two. You can be eligible for Medicaid, but not necessarily enrolled in Medicaid. You have to actively enroll to receive coverage. Eligibility, there's sort of two big key buckets of folks who are eligible for Medicaid. There's traditional Medicaid, and those are the folks who are low income and also have a disability or are the elderly, so it's considered aged, blind, or disabled. So you have to have a physical eligibility requirement as well. Or you can be a pregnant woman, pregnant person, child, postpartum. Then there's Medicaid expansion. This is what was approved under the Affordable Care Act. This is, colloquially known as Obamacare. This is what Washington State opted into in 2014. And this expanded Medicaid to just folks who meet the income threshold. So they had to be below 133% of the poverty level. It's no longer just based on disability or being a member of that special population, and it expanded to include childless adults as well as folks with substance use disorder, which was huge because previously substance use disorder was not considered a medical or behavioral concern eligible for traditional Medicaid. So as we talked about in the slide that mapped out the history of Medicaid at a very high level, because there's many other details there, 750,000 additional folks were granted Medicaid. Up until 2022, the numbers are probably larger now. I should probably update the slide to include recent numbers. But that's still a huge amount. 750,000 people were able to get onto Medicaid in Washington. But again, it's really important not to mistake the difference between being eligible and enrolled, because just because they're eligible for Medicaid may not mean they're enrolled in Medicaid, and just because they're eligible or enrolled in Medicaid does not necessarily mean they're eligible or enrolled in foundational community supports. So why are we even talking about Medicaid, right? Why do housing providers, why do supported employment providers care about Medicaid? Well, first and foremost, it's a huge source of funding. If we look at this FY23 budget, HUD has a budget of $253 billion. CMS, the Centers for Medicaid Services, has a budget of $2.5 trillion. So this is a huge untapped source of funding. Well, now it's getting tapped into, but historically untapped source of funding for the critical services that our clients, patients really need. And healthcare recognizing that these services are critical to health outcomes means that CMS and Medicaid can start thinking about ways that they can pay for it. So just first and foremost, this is a huge budget. But still, okay, on top of that, why does it make sense? Well, it benefits individuals, it benefits providers, and it benefits states as well. From the state perspective, we talked about that federal financial partnership in which the feds are contributing 50% or more to the Medicaid budget, and the states are as well. So every dollar that the states are putting in, the feds are putting in at least $1. So that's a huge influx of cash for the states to use to spend on this critical care that its residents needs. It also is an increasingly flexible source of funding, particularly because we're seeing an increase in service needs of our participants, and we need to be able to fund those services. Medicaid having that large budget and expanding its the breadth of the services it's funding to these sort of housing and employment services is increasing the pool and the pot of money that our participants who have these needs are able to access. And this also means that there's some fiscal sustainability for these service models. Unlike a grant-based approach in which you're constantly having to reapply, demonstrate the need, you don't know if you're going to get the money or not, Medicaid is an entitlement. Medicaid is not subject to budget cuts. Medicaid means that anyone who is eligible for Medicaid is entitled to Medicaid. Again, it doesn't mean they're enrolled in Medicaid. They will need to be enrolled, but it's an entitlement. So as long as that person is eligible for that benefit, they are entitled to receive funding for it. So there's an element of sustainability there that is absent from traditional service funding models. Another thing that's very exciting about the work that Medicaid is doing is that it's because there's a sustainability model, a sustainability approach. Developers of housing finance agencies, housing funders are looking at Medicaid as a strong service partner or a strong funding partner for the services piece of supportive housing. And so we've seen in Washington State, Apple Health and Homes is a new partnership between the Department of Commerce and Healthcare Authority to bridge supportive housing, the actual housing development, with the benefits themselves, with foundational community supports, and have made it so that anyone eligible for FCS is also eligible to receive a home. So this is a huge, huge opportunity as well. And again, there's an ability to customize services based on levels of need or acuity, because there are a number of different services that Medicaid can pay for. And frankly, more money equals more individuals served. The more revenue you can bring in, the more staff you can hire, the smaller the caseloads that you have, and you can end up serving more individuals. You can also, and we'll talk about this more, repurpose, funding from the COC that you may have received to opening more units and relying on Medicaid foundational community supports for services. So again, this is a huge, huge opportunity to expand your revenue potential. So we talked about why housing providers and service providers are interested in Medicaid, but why does the healthcare industry even care about housing, right? Like, it seems like they were kind of disconnected. Well, this is where we talk about sort of the social drivers or social determinants of health. These are the non-medical factors that influence health outcomes. They're the conditions in which people are born, grow, work, live, age, the wider set of forces and systems that shape the conditions of daily life. And they, as we know, have the ability to impact your health. These forces and systems include economic policies. They include development agendas. They include social norms, social policies, racism, climate change, political systems. So these are all those upstream social, economic, and environmental factors that are going to impact our community's ability, our individual ability to live healthfully. When thinking about sort of the overall determinants of health versus where we spend, if you look at the chart on the left where it says determinants, 40% of your ability to be healthy is actually impacted by those social and economic factors that we were just talking about in the previous slide. It's not impacted by clinical care, right? That's only 20%. Behaviors, your healthy behaviors are really only 30%. If we combine healthy behaviors, social and economic factors, and the physical environment, and the physical environment would be considered a social determinant of health as well, that's 80% of the driver of your ability to be healthy. So then we move over to the chart on the right, where we have historically been spending our money, and 97.5% or $3.5 trillion, and granted this was out of 2017, so the chart is a bit dated, but the point is still relevant. The vast majority of our healthcare funding, of our investments, go to direct care, hospital, providers, prescriptions, really all of the care that goes to treating medical conditions, and only 2.5% is going into public health. So there's this huge switch here, right? Where public health, which relates to all of those upstream factors, that's getting the least amount of funding. And the factors that contribute the most to your health they're not being addressed financially. Whereas all of only 20% of your health is determined by clinical care, and yet 97.5% of our expenditures are going essentially to clinical care. So the United States has been a little bit off in terms of its priorities for a very long time. And this is further illuminated on the next slide, where you look at health and social spending versus life expectancy across a number of the United States peer countries. So other countries across the globe that are similar in wealth, in economic power, they tend to spend more on their social care. So those are things like your, housing benefits and food benefits and paid time off and child care and social security, all of those social welfare benefits that we that we really need in order to thrive, most of the other countries invest more of their GDP in these social care benefits than in healthcare benefits. As you can see, social care is the dark blue, healthcare is the light blue, and yet they all have higher life expectancy than the United States. The United States is the bar at on the very far right. We invest 16% of our GDP in healthcare and only 9% in social care, and we have the lowest life expectancy compared to all these other countries. You move over to Switzerland, they invest 11% in healthcare and 20% in social care, and their life expectancy is 82.9 years old. Ours is 78.8. So we're clearly not prioritizing the right things. This is where Medicaid and health-related social needs comes in. So we talked about the social drivers. These are sort of these big systemic concerns that are going to impact our life. Health-related social needs are the specific individual needs that can be addressed that affect the ability to maintain health and well-being. So examples include housing, food, transportation, utilities, education, employment. And this is where CMS and Medicaid is looking at ways, and healthcare in general is looking at ways that we can be addressing these health-related social needs or social and economic factors that impact health directly. So because foundational community supports includes a supportive housing component, and a lot of you may be supportive housing providers, I want to touch a little bit on how lack of housing impacts your health. So people who lack housing or who are housing insecure suffer from higher rates of illness and death. Homelessness itself creates a host of new problems and can make existing problems worse. For example, being without a home is stressful and traumatic, and that's going to impact your physical and mental system. It's really dangerous. It exposes you to violence, to the elements. If you're unsheltered homeless, you're sleeping on the streets, you don't have a place to go when it gets really, really hot or really, really cold. You're exposed to communicable diseases. If you're living in a congregate setting, you're sharing rooms with 10, 20, 30 people. You don't have privacy. If you get sick, you're going to spread it easily. And it prevents the ability to engage in proper daily care. If you're worried about where you're going to sleep at night, you're not going to be prioritizing a healthy diet. You may not even have a kitchen to prepare healthy food for yourself. You probably don't. You may not be able to store your medications or even access medications or even prioritize medications. If you don't know where you're going to sleep, how are you supposed to prioritize your insulin for your chronic diabetes? And this in turn leads to greater hospitalization and emergency room visits, and healthcare is paying attention. They are recognizing that housing insecurity, as an example of a health-related social needs, is costly to the healthcare system. It has downstream effects that impact our health and in turn impact the cost of care that the healthcare sector is spending. And so we're starting to think about it, right? There's a number of different systems that have all operated in silos historically, but they serve the same individuals, and there is a need for better coordination. And that's what this is really all about. We've got the healthcare sector over here that was, providing clinical and medical care, maybe some public health initiatives, but really focused on that medical concern. And you've got social services, you have nonprofit organizations, you have, social security benefits, you have maybe city food initiatives, you've got SNAP benefits for food, maybe there's a public transportation system, so you've got sort of that social care built in. And then you have your homeless and housing systems. You've got HUD, you have rapid rehousing, you have housing choice vouchers, you have, public housing buildings. None of these entities have traditionally worked very well together, and that's really what foundational community supports and Apple Health and Homes and Corporation for Supportive Housing is really trying to address. We want to bridge these sectors to provide better care for our for our shared individuals, our shared populations, our shared communities, in order to both make sure folks are, a bit able to thrive and able to be healthy. So there's a number of different ways that healthcare is addressing these social needs. One, they're starting to screen for health-related social needs. So you may have gone to the doctor and completed, a number of questions that was maybe in your My Chart or, on a paper or on a tablet when you went to the clinic, and they wanted to know if they asked about your health history, and then they also asked about your food insecurity and if you have a place to sleep at night. So they're starting to identify these needs because they want to be able to connect patients with resources to address these needs. And in that similar vein, starting to coordinate and integrate care. So bringing together physical health, behavioral health, and social care, connecting folks who may screen positive for depression as well as homelessness with a social worker who can treat them for their depression and connect them with a house. It's healthcare is also looking at developing partnerships among healthcare organizations and community-based organizations or CBOs. So in that similar vein of coordinating care, identifying needs, really connecting with partners who can address these social care needs. And a lot of that is done sort of at that local level, but there's also more systemic or statewide and federal initiatives that are also being covered. For example, formal Medicaid benefits, like the 1115 waiver, that is basically putting into policy that the biggest payer in the country, Centers for Medicaid and Medicare Services, are going to cover some of these health-related social needs. And also some managed care organizations are exploring this as well. For example, something called in lieu of services, which is very similar in a lot of ways to an 1115 waiver. So managed care organizations are looking at it. Medicaid is looking at it. So healthcare is starting to pay attention to the important work that you all do to serve the individuals who need this extra care. Drilling down a bit more on how healthcare is addressing housing specifically, and this is similar to what we were just talking about. I like to think about it as sort of the social care, healthcare ecosystem. You have your local source of support, your local environment, the state, federal, and then broader systems integration. So at the local level, you have your hospitals, you have your health systems, you have your managed care organizations. What are they doing to address housing? Well, for one, we talked about this, they're screening for housing needs. You may have completed in the emergency room or in a community clinic a questionnaire asking how what your housing situation is. They're also investing in affordable housing. Hospitals are starting to build affordable housing on their own properties with set-asides for their own patients. Managed care organizations are looking at ways to invest in affordable housing as well. They're also serving as partners in the housing space. So providing healthcare and services in shelters, in transitional housing, and supportive housing. So partnering with community agencies, community services, housing services, homelessness services to provide additional care. So that's one way that the healthcare sector and health systems are looking at supporting these important goals at the local level. But this is also happening statewide, right? So at the state level, you have state Medicaid agencies that are responsible for setting the state Medicaid priorities. And so as you've seen in Washington and why we're all here, they're starting to incorporate housing related supports and even rental assistance into Medicaid benefits. And they're doing this through 1115 waivers, like we talked about. And also some states are taking a different authority called the state plan amendment, which you don't have to worry about because Washington did not take that route. And then they're also looking to partner with housing finance agencies to fund supportive housing. So a number of states are looking at ways to leverage these Medicaid benefits and bring together their state Medicaid agencies with their housing finance agencies so that they can co-fund supportive housing initiatives. And then at the federal level, right, we have the federal government setting these priorities as well. So for example, within the Health and Human Services, we've got the Substance Abuse and Mental Health Services Administration, SAMHSA, which already has supportive housing and supported employment as evidence-based practice. So they encourage these sort of upstream approaches to address healthcare. Additionally, CMS has, pays for these 1115 waivers to cover housing supports and rental assistance. And a recent initiative that I believe Washington was approved for is something called the HUD and ACL Accelerator. And this is a way at looking at states who've received Medicaid funding for housing services can bridge their housing agency and their housing work with their Medicaid work, with their services work, to really look at how we can integrate those systems better. And then similarly, when you go a step further at this really big sort of systems integration work, we're looking at benefits alignment. So how can we streamline entrance into housing with approval for foundational community supports, for example, or enrollment in Medicaid? How can we integrate data systems? How can we make HMIS talk to your EHR, for example, or for those who are not familiar with that acronym, your electronic health record? How can we collect and share data? Because we know we're serving the same individuals. There are state-led systems alignment. For example, Apple Health at Homes, that is bringing together Department of Commerce with state Medicaid agency, with the Healthcare Authority. And then federal systems alignment, like this HUD and ACL accelerator that I mentioned. So there are two big moments in Medicaid history that I want to call out that specifically relate to housing and health related social needs. And I referenced one of them in the timeline. So this was 2015 CMCS, Center for Medicaid and CHIP Services informational bulletin that instructed states that Medicaid can be used to pay for housing related activities. So these are things that include the housing transition services, or what we call like pre-tenancy supports. So that's services that support an individual's ability to prepare for and transition to housing. And then also the individual housing and tenancy sustaining services. So those are the services that support the individual being a successful tenant in his or her housing arrangement, and thus able to sustain or maintain their tenancy, prevent eviction. So this is the community support services component of foundational community supports. But in 2023, CMS put out an informational bulletin, as well as what they call their health-related social needs framework of services, which provided further instruction on how states can leverage Medicaid to pay for various other housing, health, and transportation-related services, including rental assistance. And so this HRSN framework of services is something that Washington has also been taking advantage of. And with their new waiver amendment, have been approved to actually expand the work that they're doing to actually incorporate some of these other health related social needs as well, including rental assistance. So bringing this all back to the context of supportive housing, and I know for folks who are just in the supported employment vein, we're doing a lot of housing work here, but we are the Corporation for Supportive Housing, and half of FCS is really focused on housing. So that's sort of the angle that we're tackling this by, but it applies to employment as well. Within the supportive housing vein, we talk about this sort of three-legged stool of supportive housing. You need funding for capital, so you need to develop or rehab buildings. You need funding for those operating costs, so how you maintain the building and provide rental assistance to your tenants. And then you need funding for services. And as service providers, I'm sure that I am not sharing anything new when I say that services have historically been grossly underfunded. And so Medicaid, as we talked about in a few other slides, and really the theme of this entire presentation, Medicaid is a great source for increasing those services. And it makes sense, right? Services are related to healthcare. We provide social work and case management and behavioral healthcare in healthcare settings. Housing case management is just an additional layer of that. And it makes sense for Medicaid to pay for that. And then you'll also see in that little asterisk and rental assistance. Now, in certain limited contexts, Medicaid is actually paying the rent for 6 months for certain eligible individuals. And that is huge. For the longest time, Medicaid said, we're never going to pay for room and board. That is not what Medicaid does. Well, they're starting to change their mind. And that's really, really important because we also know that HUD vouchers are not limitless, and having additional sources of revenue to help get someone into housing and help get them off their feet is so hugely important and very impactful. So this is a map of all of the states across the country that are looking at establishing housing or health related service benefits within Medicaid. So the purple states are those that are already operating their benefit. As you can see, Washington State is purple. It has had foundational community supports, that 1115 waiver since 2017, 2018. So it's already operating. And the number of states that are looking at operating are growing. You know, there's more purple than a number of other colors there. Blue are negotiating. Their state's Medicaid agency is currently in the process of negotiating a similar benefit with CMS. That's Illinois, that's Montana, that's Colorado. So 3 other states are currently applying for a similar benefit to Washington. And then 3 other states are currently in the planning process. They know that they want a benefit like this. They don't know what that's going to look like yet, so they haven't officially applied. They're planning, and that includes Virginia, that includes Nevada, that includes Utah. And then we've got state planning post CMS approval. And that means that the state has been approved for a benefit like Washington's, but is still in the process of developing its implementation protocols. They're still designing what that's going to look like now that they've been approved to do it. And that includes Arizona and New Jersey and Vermont and New Hampshire. So now we're going to pass it over to Stephanie, and she's going to talk to you specifically about Washington's Foundational Community Supports Program.
Thanks, Eva. And just really quick note, unless you have all of those states written down, I'm very impressed that you were able to name them so quickly, because I would have had to sit there and think about which state was which. So go you. Thank you. We're going to be chatting about, like Eva said, the Foundational Community Supports benefit that's in Washington. And what is FCS? FCS is Washington's target Medicaid benefit that helps eligible clients with complex health needs obtain and maintain housing and employment stability. So it provides supportive housing and supported employment services to folks who are eligible, oftentimes are the most vulnerable folks that we're working with, right? They need additional support, they need additional interaction and engagement and outreach. And the hope is that providing these services by helping them find and retain their housing, by helping them find and retain employment, we are promoting self-sufficiency and recovery. And that looks different for everyone we're working with, right? So we know this isn't going to be like a cookie cutter process for folks, but being able to offer tailored, individualized supports to folks will help them achieve self-sufficiency and recovery, whatever that looks like for them. So the eligibility for the supportive housing requirement is that folks be 16 or older, that they meet at least one of these health needs-based criteria. So that's having a mental health need, a need for substance use treatment, complex health need, and have at least one of these social risk factors. So they've been experiencing homelessness for at least 12 months. They have 2 or more contacts in the last 12 months with an institutional setting. The list is here for you to read. And for supported employment, again, folks need to be 16 years or older, also meet at least one of these health needs-based criteria similar to the supportive housing eligibility, and have at least one of these social risk factors. So being unable to be gainfully employed for at least 60 days consecutively due to their health. And the list is there. So supportive housing is really looking at the relationship folks have between their health and their housing, and supported employment is looking at the relationship between employment and their health, right? So that's the big piece. If someone's health is impacting their ability to get housed and to stay housed, or to get and keep a job, and they meet these eligibility requirements, then we can offer them supports through foundational community supports to address some of these barriers and to overcome some of the barriers that may be preventing them from achieving some of this self-sufficiency, some of the stability that they're oftentimes really craving and needing, right? And so Eva touched on this, and I feel like this will be a theme throughout the presentation, but there's a big difference between being enrolled in services and being eligible for services, right? So just because folks are enrolled in Medicaid does not mean that they are necessarily eligible for FCS or that they are enrolled in FCS, right? So you have to you can see that your folks might be eligible, might meet most of these requirements, and then we have to do the legwork to get them enrolled into FCS to be able to receive these benefits. And we are just talking really briefly, very briefly on supported employment here, just to give you the overview of the benefit. But as Eva said, we're really focused on supportive housing. That's the piece that we bring expertise on. So if you have specific questions on supported employment, we will have the contact info for the HCA trainers towards the end of the presentation, and you can reach out to them with specific questions. And these trainers are available for supported employment and supportive housing providers. So if you have any questions, they're your go-to. And going back to eligibility and enrollment, these trainers can be really helpful in identifying workflows and coming up with creative solutions with you to get the information that you need from folks creatively, right? It's not as easy as getting somebody to come into the building and fill paperwork out. So they can help you figure out what creatively can be done to get folks in, for you to get out there and meet with folks to get this information you need to get them enrolled in these services. Somebody had their hand up. I think MJ, but you put it down. I want to make sure that if you have a question, you can put it in the chat.
I was just going to ask about the institutional settings. Like what's defined as the institutional setting? But I can get into that later with when asking questions later on the specifics of that.
Yeah, Stephanie, do you want me to take that or do you want to take that?
Oh yeah, no, go ahead. I was trying to pull up my note on that. Yeah, go ahead.
Yeah, so an institutional setting includes like what we would call like an institutional mental disease or like a state, hospital for folks with behavioral health concerns. It includes a skilled nursing facility. It includes a carceral setting. So anything in which you are, living in a congregate setting outside of the community, if that makes sense.
Okay, yes, that makes sense. So thank you.
You're welcome.
Great, thank you.
Oh, wait a minute. One other question. Does that include a hospital hold for an evaluation?
That's actually a really, really good question. If a hospital hold is considered an institutional setting, when I
worked for HOC, good Lord, I can't tell you how many times I called what's now Frontier Behavioral Health to come out and assess somebody for detainment except for psychiatric emergency, and where I've had somebody done as if and they'll hold them there and they've had them there and stabilized them, but they haven't necessarily gone to like Eastern State Hospital or anything.
Yeah, so I think that it actually probably would not be considered because you have to have been in an institutional setting for a certain amount of time, right? So you have to have been in an institutional setting 2 or more times in the last 12 months or 90 or more consecutive days. So a hospital hold would probably not count as that. I doubt anyone's been held in a hospital for 90 more days.
No, not that long. I'm just wondering, like, if it's like if they were like held for like 4 days one time and then like a few days another.
That it might work because if it's 2 or more contacts in the last 12 months, like if they've been hospitalized, but I can follow up on that specific detail.
And Rayanne put in the chat that sometimes, yes, each case can be a little different, and connecting to your trainers would be really helpful in the situation. So again, we'll have that information at the very end. Because I think it is case by case for some of these.
All right. Thanks. I'm like, as a social worker, when you're working and looking at these here, you're always looking for the loopholes of, geez, they don't quite, let's see, how does this?
Yeah, no, it was a great question. I'm sure that there are other folks who have similar experiences. So thank you for asking.
All right.
And everyone, please feel free to continue to drop your questions in the chat, come off or to raise your hand, and we'll get to them as best we can. Because yeah, we don't know what you need to know unless you ask, right? Next slide, please, Eva. Cool. So this slide is a map. This represents a map that an individual asking to be enrolled in FCS can go through to be enrolled. And so there's 3 different routes that somebody can become enrolled into FCS. The individual can self-refer. There's a self-referral form on the website, and they can send that directly to WellPoint. They can connect with a referring provider who has no FCS contract, or they can connect with an FCS partner who is contracted. And the system or the map, the process kind of it looks the same for down the line for all folks. It just kind of you deviate a little bit depending on where you go through. So you'll be, if an individual self-refers, they'll go through WellPoint will go through all of these systems and then get to assignment and assign them to an FCS provider that is contracted, who will then do an assessment, send that back to WellPoint. They will do the eligibility determination, service authorization, and then get that back to the FCS provider. Or you could not be coming from a referring provider and kind of go through that same process. So this is just kind of maps out really quickly what the process is for referral. And what we touched on briefly earlier, Washington's third-party administrator, WellPoint, which used to be Amerigroup, and one of their big roles is to process these referrals to check eligibility to enroll folks in the FCS program. So they're one of the biggest points of contact for folks. Next slide, please. So Eva touched on this really briefly earlier. But what is covered in supportive employment, in supportive housing under the FCS benefit? It's pre-tenancy supports, right? So anything that folks need to move into, to find housing and to move into housing. So that's any of the needs assessments that you're doing, any referrals you're making to community partners, helping them work out budgets, helping them connect to other service providers and other housing resources, starting maybe a case plan or an action plan that identifies their short and long-term goals, with the goal of getting them into housing. And then you move on to the tenancy sustaining services, which is how do you help them retain that housing, right? How do you help them stay stably housed? How do you help them avoid an eviction? And so again, that's service planning support. So you're action planning with them. You're creating these person-centered goals where they're leading the work, they're leading all of their treatment, all of their journey with you. You're supporting them in living independently. You're helping them navigate landlord-tenant relationships. You're providing them education on what it means to be a renter. So one is getting them into housing, and the other is keeping them housed, wherever that looks like. And I think that oftentimes with tenancy sustaining services, we think about keeping them in the same housing for as long as possible, and that could be the goal for a lot of folks. But oftentimes that means that you're doing some eviction prevention work, that you're helping them get out of the situation before they get evicted, that you're helping them move into a more stable, more suitable housing option for them, because we know, especially in the housing market now, the tenant choice is really hard, right? Because you're just trying to put people into the first available unit. And so tenancy sustaining services is really about helping them get into the best housing for them and to sustain housing long-term. And lastly, there's the transition assistance program. And so this is time-limited flexible funding to support housing-related fees. So we're going to touch a little bit more deeply into that in the next slide. Next slide, please, Eva. So the transition assistance program helps cover fees that are often barriers to renting a home or getting into housing. And this could include things like IDs, application fees, moving costs, and more. You can see them listed here. And if there are requests that fall outside of these categories and it's a barrier to housing transition for your folks, providers can request an exception to WellPoint. And these can be things like mattresses, paying rental arrears, or paying for reasonable modifications to a unit, depending on what your folks need. And please note the asterisks on these amounts. These are last year's numbers, and funding amounts are subject to change based on the availability of these funds, but the HCA is going to share out updated guidance before the next funding cycle, which I think is in July. Next slide, please. And again, so just a general overview of the TAP, the Transition Assistance Program. To access this TAP, you fill out, it's online now, so that's exciting that you're not having to fill out a physical form and send it into like an email. There's an online form for you to complete the reimbursement form that you submit online to WellPoint. WellPoint will respond to your TAP request within five business days with your approval, your denial, your rejection, or requesting more information. And then once it's approved, you'll be reimbursed through an electronic funds transfer or a paper check. And it's noted in the provider manual that the electronic funds transfer is quite significantly faster than a paper check. So if that makes you want to choose one over the other. But please note, this was hard for me to find, but please note that providers need to have an FCS TAP contract amendment signed and submitted, an additional credentialing completed before requesting TAP funding. So you have to go have this additional contract amendment with WellPoint to be eligible for before you apply for this funding. And so you can reach out to the FCS team for more information on that, or reach out to if you have a contact at WellPoint for more information on what that looks like. Next slide, please. And so what's covered in supported employment? Similar to supportive housing, there's all of the pre-work that you do to get somebody prepared for and transition into competitive employment. So that's any like assessments that you're doing, any planning that you're doing, individualized job development or trainings that folks may need to move into or to start working. And it's educating them on their benefits, what they're eligible for at work, helping them set up transportation. And that's right before, as you're planning to get them into work. And the employment sustaining services are helping them maintain competitive employment. Again, like supportive housing, it's not about just keeping them in one placement for as long as possible and helping them maintain that. For some folks, that's what they want. They want this one placement, they want this job, they want to be able to move up within this job. But it's also looking at career advancement services, looking at other options in a similar field, but maybe at a different organization where there's more upward mobility, or there's more flexibility, or there's more engaged management that's willing to work with them. You're also helping them negotiate with their employers. You're advocating for job accommodations. You're following up with them. And with all of these services, with the supportive housing services and the supported employment services, none of these are time limited, right? They're available as long as the participant is enrolled and as long as they're interested in receiving these services. So they could be enrolled in these services and decide tomorrow, like, okay, I got my job. I don't need this anymore. I don't want to chat with you anymore. And that's fine if that's what they want. But as long as they are wanting to work with us, as long as they're engaging with us, it's our job to engage them. I used to tell myself when I was working in supportive housing, I used to tell them that services were voluntary for our participants, our clients, but they weren't voluntary for us, right? Our job was to engage them and to make the services that we were providing appealing and individual enough that our folks wanted to engage with us, that we were tailoring services enough that our folks felt like, yes, this is meeting my needs, but they keep wanting to engage with us, that we could continue to support them. Next slide, please. Oh, next one is back to Eva.
I was speaking and I was muted. All right, thanks, Stephanie. So there are a few things we want you to think about as you're considering becoming a provider. So there are a few key points, and we touched on this a little earlier, but there's participant eligibility for Medicaid, participant eligibility for foundational community supports, and then provider enrollment in Medicaid and or foundational community supports. So first and foremost, is the individual that you want to assist eligible for Medicaid? You need to identify that. And then you need to identify whether that person is enrolled in Medicaid. And if not, what is required to get them enrolled in Medicaid. And all of these resources are available to you on the HCA website, which we have shared in future slides. Next, you need to think about whether, or you need to identify whether the participant is eligible for foundational community supports. So are they eligible for FCS, and are they eligible for SCS community support services, which is what FCS calls the supportive housing services provided? And then are they eligible for FCS supported employment services, if that's what you are looking to offer? And then finally, is your agency enrolled in Medicaid to provide FCS services? Again, these are all things that are going to be offered to you on the HCA website, specifically all of the steps to become an FCS provider and to enroll your participant in FCS. And then, does my agency have a contract to provide FCS with WellPoint? You don't need to be contracted with WellPoint to provide FCS, but it can be helpful. And Rayanne, if that has changed, please hop off mute to contradict me, but I'm going to assume that that has not changed since the last time I presented this.
Thank you for calling that out. The agency itself needs to be contracted, but individual staff or providers don't need to have a separate contract. But the enrollee is basically assigned to you and your agency, so you would be the only one able to bill for that person. So someone might be enrolled in foundational community support, supportive housing, but you as the agency assigned to them would be the only ones able to bill. Any other agency or provider wouldn't be able to provide those specific services to them and get reimbursed for them unless they're a contracted provider with WellPoint.
Thank you, Rayanne. So there's another key point that I want to raise that is really critical for providers to keep in mind. Many of you are used to the grants world, and administratively, things look very different. So you're used to writing your proposal for a grant. Maybe the funding covers 1 to 3 years generally, and then you get paid. You apply for funding, you get paid. Maybe it's quarterly, maybe it's annually. You provide those services, and then you write your funder report, and the cycle starts over again. Medicaid administratively looks very, very different. You got to apply or enroll as a provider, and generally this is once every 5 years. Then you have to have a managed care or third-party administrator contract, generally good for 1 to 5 years. You have to make sure that your members are enrolled. You have to authorize them for services. So once the member or client is enrolled, not only in Medicaid, but in enrolled in Medicaid, they have to be authorized for those specific services. And that's generally on a 6 to 12 month basis. I think FCS is annually. Then you serve your authorized members. If you serve them before they've been authorized for their services or enrolled in Medicaid, you will not be paid for that time. Then you submit claims once they've been, once the service has been provided, generally on a monthly basis, and then you get paid, and that can be after 30 to 90 days. And that process renews and renews and renews. So it looks very different. It's not applying for funding and then getting paid. It's enrolling as a funder, then providing those services, and then getting paid. So there is something to keep in mind, which is you need to make sure that you have enough money in your coffers to support you throughout the process while you're waiting for those claims to come in. Additionally, Medicaid, and you're going to hear this term over and over and over again, Medicaid is to supplement, not supplant existing funding. What that means is that you can use Medicaid as an additive to your source of funding, but you cannot replace existing funding with Medicaid. It allows you to improve your service quality instead of replacing your funding sources. For example, you may receive COC HUD funding already for your supportive housing program. As long as COC HUD funding exists, you'll need to continue to use COC HUD funding. But you could maybe apply your COC HUD funding to units, to unit creation, to rental assistance, and use Medicaid for the services that Medicaid covers, but you cannot replace COC funding with Medicaid. So you're going to hear this over and over again, and one of the resources we provide in a future slide is the FCS supplementation versus supplantation guidance document. And this can be confusing as well. So your FCS trainers are always available to answer questions if you're confused about what you can and cannot do with this funding. But really what it's intended to do is diversify the folks that you're able to serve more people, increase the services that are provided. And frankly, you can reduce caseloads because more service funding means more staff hired, means fewer cases to staff member ratios. Another thing to keep in mind when you're looking at bringing Medicaid in is that you want to think strategically about how you're using and distributing your funding sources. You want to dedicate your flexible funding or the sort of catch-all funding like COC funding to broader needs that are not covered by existing streams. Medicaid can cover very specific services. You'll want to use Medicaid to cover those very specific services, and then you'll want to use your other sources of funding for more flexible services. And there are a variety of resources that can talk about how to successfully blend and braid your funding streams. And then you'll also want to, as you're moving towards the process of becoming a Medicaid funding or Medicaid billing provider, think about your capacity and your bandwidth to really bring this on, because you're going to require some startup funding. And I believe that the FCS team has some infrastructure funding that can help, but you may need additional seed funding to allow you to build the infrastructure that you need to build Medicaid, whether that's buying, a billing software or HIPAA compliant software. You'll want to make sure that you have the right partners that are working with you on this work and that your referral pathways are set up effectively. There's going to be implications for your data management. I mentioned HIPAA. You're also going to need to really focus on quality improvement. There are a number of those data requirements with Medicaid. Claims and billing is a huge and complicated process. And so there are a number of resources out there to help you with that. You have your WellPoint team, you have your foundational community supports team. So you'll need to think about what it's going to take to bring you up to speed with claims and billing, as well as whether you have the funding to sustain yourself while you're waiting for that claims funding to come in. Is your organization ready for this change? So you might need to engage in some change management and getting your staff comfortable with what will be quite a significant shift. Medicaid comes with a lot of documentation, and that can be a culture shift in your organization where you have case notes, maybe you document a bit, but it's not the priority. There's going to be a big shift where documentation is critical, and it has to be done the right way. You'll want to make sure that the decision making is done inclusively so that everyone's on board. And this again goes into sort of change management and effective change management, making sure that everyone from the executive team, the C-suite, to your board, to your frontline staff who are going to be engaging in this work are included in some of these decision making. And then thinking about what training, what technical assistance, and what work plan development you'll need in order to bring things up to speed and really sort of bring things to fruition. And the FCS team has a number of training and TA resources available on their website, and CSH is also available to you as well. In that vein, we are sharing out with you a number of helpful resources to kick things off. There's a ton more information that we can share, but we don't want to overwhelm you at this juncture. So if you're interested in learning more about broader social determinants of health and health-related social needs, there's a CSH explainer on the relationship between housing and health, a Center for Healthcare Strategies explainer on just general social determinants of health, and then also the CMS informational bulletin on the health-related social needs framework of services. And then some additional Medicaid resources, including the website for the Washington Healthcare Authority, how to apply for Apple Health, And apologies if you can hear my dog barking. The buzzer just went off and she's a little bit of a nut. And then a link to the updated 1115 waiver. It's very wonky. Don't feel like you have to read it, but if you're interested in health policy, you can read all about it. And then finally, some FCS resources, including HCA's FCS resources page, WellPoint, our third-party administrator's FCS website, the FCS provider manual, which you all should read because that is where the source of truth for how to be an FCS provider, the FCS quick reference guide, and the FCS supplanting versus supplementing guidance. And then finally, there's some additional training materials. CSH has a Medicaid Academy that we've put out in the past that we've linked to here as well. For additional questions, you have a huge team wanting to help you. So if you're interested in becoming an FCS provider and you haven't kicked the process off yet, you can contact the trainers. Dawn Miller and Darren Paschke are your supported employment trainers, and Anessa Williams and Jackie Velasco are your supportive housing trainers. And if you're already in the process of becoming a provider, we have Rayanne, and you can reach out to her and she'll help you out. Finally, we highly encourage you to join the monthly Q&A and quarterly advisory council meetings. If you're interested, you can email the FCS TPA at wellpoint.com and copy Jacob Avery. And I'm gonna pass it back to Stephanie to close things out, and I am going to go off camera while I tell my dog to stop going crazy.
Well, thank you, Eva, for that. I always learn so much, even though we've done this a couple of times, learn so much from watching you train. I hope that everybody else there was some value in you attending this session. I popped our eval link into the chat, so please fill it out. Any feedback that you can provide is always really appreciated, and it helps us tailor our content the next time we do a session like this. We are providing another session on April 27th on the Foundational Community Support Services Budget Tool. And this is the Services Budget Tool is a CSH tool that we put together to help folks kind of plan for and budget for this one specifically, how to utilize FCS. And so Eva will be leading that training in about a month, and then we will be doing office hours 2 weeks after that for folks who have questions and are interested in utilizing that tool. But thank you all. Can you please put up the advisory email again? Is in the chat. Eva, can you pop that in to the chat? But thank you all again for joining. You have our emails, you have Rayanne's emails, we have the trainer emails in this slide deck. We will be sending out links to this following the session, probably by Fridays, my goal, with access to the recording, a copy of the slide deck. And so you'll have all of the links that Eva shared and all of the contact information. But yeah, thank you all for being here. I'm going to stop recording.